Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 47 of the OBGYN podcast. Just a quick note today before we get started. I am always on the look for new podcasts, new material in OBGYN, and when I find one, I like to share it with you all. So I did find a new one. It's from two third-year residents at Brown University in Rhode Island, which, as a note, is where I grew up, so there's a special place in my heart. But they started a new podcast called Creogs Over Coffee, and they're putting together very nice, concise, 10 to 15-minute reviews about different topics in OBGYN. The first two are amenorrhea secondary and primary, talk about pregnancy physiology. It's really aimed at residents, but I think medical students, midwives, attendings, anyone who wants a quick refresh on a topic would really find it valuable. So I put a link in the show notes. If it sounds like something that's interests you, go check it out. I think you'll really like it. Today is the monthly checkup for November 2018, and I am very excited to have two wonderful guests with me to talk about really a very important topic in all of medicine, but I think it touches OBGYN specifically because of our gender makeup in our profession. Now, we've touched on this topic various times in the past year, but there were two articles in the New England Journal of Medicine last month which really made me think about it again in a new light. So today we're going to talk about really medical student mistreatment and medical student harassment due to gender and sexism. To help me walk through this very important issue in medicine is Dr. Sara Kim again. Welcome. Thanks for coming back.
I'm glad to be back again.
And a new voice for us, and that's Dr. Umesh. Thank you very much for joining us.
Super excited to be here.
So the first paper, well, actually both papers, really talk about this National Academy of Sciences, Engineering, and Medicine 2018 report, where they catalog sexual harassment in different fields, science, engineering, medicine, go figure. And what they really found that was striking to me was a profound difference between non-science and engineering and even science, engineering, and medicine. And medicine was a big outlier here. And just to give some top-line numbers before we get into our conversation, 45 to 50% of female medical students experience some form of sexual harassment or gender-based harassment during their training, which, I mean, really is just astounding. And you would think that males, maybe they're a little less prone, but still 21% of males reported some gender-based harassment, which is really just striking to me. And before we get into the rest of the editorials here, I kind of want to, hit you two guys and say, what do you feel about this? Is this something that you felt in your training, something you feel now? I don't put you on the spot. You don't have to tell me any personal stories, but kind of, where does this sit with you? Does it sit right? What do you think, Dr. Kim?
I personally, I found the numbers very shocking. From my own personal experience as a medical student, I don't think I ever felt that myself. In terms of, feeling that I was treated differently just because I'm necessarily a female, or I felt that there was like any sexual harassment. But which is why for me the numbers are shocking, and it's very sad actually to see that as well. In terms of how in my training now, I think, and the paper does talk about it a little bit, I haven't necessarily experienced it within my residents, because they're right now currently all females, but I definitely have felt it from patients. And the article does talk about that in terms of me being a female. There's not only female, but a little bit younger. There's definitely some bias of, them wanting more of an experienced male physician kind of in the room, and how they treat the male physicians a little bit differently from me. Granted, yes, I am a resident training, but I could tell that some patients kind of express a little bit more comfort they feel the male of attending there, who they feel is more competent and proficient in what they're doing. So I definitely, for me, so far in my training, I felt it more as from the patients necessarily than from my co-residents or colleagues.
I definitely feel that sometimes too. When I go in with residents, I definitely feel what you're talking about. Mm-hmm. What do you think, Dr. Umesh?
So echoing some of what Dr. Kim said, I mean, the numbers are definitely, when you see them put on paper, they are remarkable and definitely shocking. But in my medical school experience, I felt, especially as looking at how they've defined sexual harassment and inappropriate treatment, it sort of saddens me to say I've definitely seen some of this not necessarily in my own experience, but in what some of my medical school colleagues went through. Simple example, we had a preceptor, an outpatient preceptor that has since, not been taking in students. And the main reason is because it was a very well-known thing that this preceptor was inappropriate towards female students, made inappropriate comments. So the solution was not to reprimand this person, but just to stop female students from working with him. And so the article, I guess we will get to that at some point, does sort of touch on this idea of how we view these issues as individual issues. So if we sort of put a Band-Aid over that one isolated instance, it sort of takes, there's no other big issue that we're dealing with. And I found that very interesting because I've seen time and again, we point to one individual and say, well, that person has something that's going on. And as long as we fix that, then we don't really need to deal with the larger perspective. So
I think you're absolutely right. I have seen exactly what you're talking about. I've seen it at every institution that I worked at, where there is usually an attending who just, it's not even they act inappropriately. Everyone knows that they act inappropriately, right? It's a well-known fact. And for what I've seen for most of the women who are involved in that is they're warned, but this is how this person is, just ignore it, right? And how terrible is that? But I think that gets back to your individualism, and I do want to save that for a little bit later, because I think it's an important aspect of it. But let me stop there. Let me go into the different kinds of gender harassment, because I think the numbers here are eye-popping for a reason. And so they break down their sexual harassment or sexism in medicine down to three things. There's gender-based harassment, which can be anything from a crude remark or a sexist remark. It can be ambient or it could be directed. Right? So you could just have one person sharing another story or a picture or something with somebody else, and that's an ambient gender-based harassment, right? You could have, and I guess that's probably the most prevalent, right? That's kind of what we probably see most of the time. Then there are the truly egregious things, the unwanted sexual attention, whether it be verbal or physical, commenting on, people's appearance. And then there's the worst, which is definitely sexual coercion and trying to use your position of power to get something, get sex from somebody. And that obviously is horrific. And thankfully, most of the people, male or female, didn't really experience that, which is good. But I think why this study has such eye-popping numbers is because they've done something that goes to this zero tolerance policy, and that is, have you ever seen or been involved in one of these activities any time during your medical student career? And I think all of us would say yes, right? I'm surprised it's only 45%. Right. Because I think most of us have been in a room where it happened. So I was surprised 45, but I think we do this with patient satisfaction. You are either, if you don't get an always, if the patients weren't always satisfied or your pain wasn't always controlled, then we don't get credit for that, right? We get dinged if it's an always. And I think that's the way this study was worded and why our numbers are so high. And not to say it shouldn't be like that, because really there should be a zero tolerance for this kind of behavior. But I think it's where it differs from other papers. I don't know. What do you guys think about that? Dr. Kim?
I definitely, part of it, I think, is the awareness, not only of the maybe person, kind of group awareness, kind of going back to what Vi was talking about in terms of culturally, if the place kind of accepts it, then people may just shrug off some comments as it is what it is and not even look at that as harassment. So, but if you delve more into it and say harassment actually is defined by XYZ, I think people may say, actually, that is harassment. But all this time when I was, with this person, I thought it was not harassment because everyone else said it was fine. And, everyone accepted as it is what it is. So I think giving a more fuller definition of what harassment entails, I think this was important because then that raises awareness not only for the person who is being harassed, but maybe even the culture of the place itself, thinking, oh, actually, what we thought was just the individual is actually more of a cultural acceptance of such harassing behavior.
Yeah, absolutely. I think the zero tolerance policy is interesting because I think it does shed some more light as to how many true cases there really are. However, the one I guess thought that I had regarding that is, I wonder if making it almost binary like that washes out some of the nuances and the subtleties, and maybe doesn't shed light into situations that, you know, have the potential to turn into something that could be construed harassment, but instead, because it doesn't fall into this absolute category, whether or not people don't view those things or don't view their situation as equally or having an equal potential to turn into something that would fall into one of those categories. I don't know if that made sense, what I'm trying to allude to.
I think it does. I mean, most social interactions aren't black and white.
Exactly.
Right. But the issue, and actually I'll tell a story that isn't about sexual harassment, but it gets to what the point you're talking about is it's all about people's perception of that. And it's hard to know ahead of time what people's perception will be. So I used to give a lecture for the medical students. And for those who know me, and I don't think anyone who listens to the podcast will be surprised, I like to have a fun time. I like to joke around a little bit. I like to keep it interesting. And so we were talking about preeclampsia and who's at risk for that. And one of the things, when we talk about diabetes a little bit, so anyway, one of the things that was at risk was being Asian, right? So there was an Asian medical student. So I said something like, well, you're going to get diabetes and preeclampsia, so maybe you just shouldn't get pregnant, right? And right. And so that actually somebody, and it actually wasn't that particular medical student, it was somebody else in the group, complained about my remark. And I had to go talk to the dean and whatnot. And I accepted that. Obviously, I mean, that's kind of borderline. And somebody was offended. It didn't even have to be the person who I said it to.
Right.
But all that mattered, whether I thought it was offensive or not, is that someone there thought it was offensive.
Right.
And I think that comes down to sexual, especially the gender-based harassment, the crude sexist remarks. And I try to be careful with this as well, because I like to joke around with the residents. I feel like relatively close, and as close as attendings and residents should be. And I catch myself sometimes saying, I probably shouldn't say that because somebody here may, feel
misconstrue that,
correct. Or the residents may have no problem with it, but the medical students don't know me. And they're sitting in the room too, and they may think, well, that's really weird to say, whereas the residents would be like, oh, okay, like we're just joking around and that's fine. And so deeper than that, though, is does it matter if only one person is offended? Is that enough? Right? And I guess it depends on what the system to address that is. Right? If it's a zero tolerance, you're fired. Well, that's probably not okay for that kind of thing. I mean, obviously, if you're doing unwanted sexual attention or sexual coercion, I think there's no place in any work environment, whether it be medicine or anywhere else. But if it's one person was offended by what you're doing, I think there has to be some counseling in there that, hey, maybe 99% of people are okay with that, but not everybody. So leave that at home and don't say it in the workplace. I don't know. Does that kind of talk about what you were getting there?
Yeah, exactly. So in fact, I had seen an interesting table once that had defined actions that were definitely medical mistreatment of students and actions that could be perceived as medical mistreatment of students. And I think that's exactly what you're alluding to, where, yes, there are definite scenarios where it's a no-brainer. This is inappropriate. It doesn't matter if the person receiving this thought it was inappropriate, but just by the virtue of the action, it's inappropriate. But I think there's this whole category that you're referencing where maybe one person has a problem with it. One person interpreted what was going on as inappropriate, but the other person didn't. And I think it's this gray zone that I find very interesting because the question really becomes, how do we define it? Is it worth defining? And is there a metric by which we should outline individual actions and have an algorithm almost approach to how we view individual complaints? And there may not even be a situation because on some level you are also taking out all social interaction and, just general conversation and personalities if you overanalyze things. So,
and the issue is it's more complex than just simple comments or simple gestures because the interaction, the relationship is actually complex. It's hierarchical, and that also makes it more complex. So a comment that I could make to my own co-resident, if I say it to a medical student, they may be very offended by it, even though my co-resident has no issue with it. Or even vice versa, like the medical student, in case they say something to their own med students, and if they say it to me, I might find it offensive just based on the dynamics of the relationship, and that adds layers of complexity to what do you perceive as harassment.
Well, let's take that and go down into why we think that it's such a pervasive problem in medicine as opposed to some other fields. And hierarchical is the first one on our list, right? You're absolutely right. Like whenever you have someone in an inferior position to you, they are vulnerable. And they're vulnerable because, one, they have to listen to you. Maybe they have to do what you say. And also, they feel like there may be some retaliation if they report that. Right. Whether it be in the military or in medicine, and residency especially, although it's getting a little less hierarchical these days, I feel like it's still that if your chief resident tells you to do something, well, you're going to go do that, right? Or you may not, and there may be some consequences for that. So that's part of that process. Now, in OBGYN, where it's all female, and not that females can't sexually harass other females. Obviously, that can happen, although probably to a lesser degree. And one thing, actually, before I forget, I really like their gender-based harassment term. I thought that was really nice. And they get into, it can be male, it can be female, it can also be sexual orientation, could be transgender, it could be all that stuff. So I really like that gender-based harassment. I kind of want to use it more. But so certainly hierarchical. They talk about being male-dominated field. And we talked about this a monthly checkup from a few months ago about lack of female leadership in all of medicine. But even in a female-dominated field like OBGYN, still most of the leadership is male. Right.
Yeah.
And so what do you do when your division directors are all male, your chair is a male, maybe your program director is a male, and then you feel like you've been sexually harassed as a woman? Like, where do you feel comfortable bringing that to?
Right.
That's got to be hard. I mean, I'm not female, obviously, but I feel like that's got to be a hard thing to talk about. What else do you guys think? What other reasons do you think in medicine really lead to this besides that major stuff? Dr. Kim, what do you think?
So I also think kind of going with what I was saying, the fact that it's also a very high stress, busy environment, I think attributes to being able to kind of brush off some of these things as, okay, it's part of my job for me to just accept this. They kind of just accept some degree of suffering as a matter of course. And I thought that I think pervades the culture of medicine in some ways, saying like what we're doing is very competitive. I need good grades. I just have to kind of accept this as is. And I think that, not that it makes it okay, but I think that's why some of these, episodes of harassment could just kind of be overlooked, not only by the medical students themselves, but also by the institution. And I think medical students probably feel that there will be ramifications if they say something, because the culture is like, it is what it is. You are medical students learning in a very high stress, high competitive atmosphere. We want to make you survive this, and you have to kind of accept that there is going to be some degree of suffering. And I think having that mentality doesn't necessarily make it okay, but maybe that's why there's a little bit more pervasiveness of harassment in medicine versus like the sciences and engineering, because you are working long hours. It's very extensive workload, it's very competitive, atmosphere, that you don't want to necessarily show yourself as a weak person by admitting that this is happening to you. And another thing that I think is another maybe pervasive to just medicine in general, and I don't know actually what the supervision is over sciences or engineering, is that there really is no direct oversight, and the paper mentions it, by their program leaders of, if this happens, this is the person that you have to turn to, and XYZ is going to happen. It's not really like outlined anywhere. So there's nobody overlooking to be like, okay, I'm going to make sure that every interaction that a medical student has is appropriate. It's kind of hard to do that. It is a workplace where things are happening, it's dynamic, things are changing. Whereas I think in other places that are a little bit more, I guess, not as fast paced, there are different definitive people that you turn to if like something happens. You could go to like human resources, you have someone to turn to, and that's not really readily available, I think, for medical students.
Yeah, I mean, medical students or residents, really, both of those cohorts exist outside the normal corporate structure, right? If you work, even outside a state institution where the residents basically work as part of the state, like I didn't see HR as something that I would go to. We didn't hear from HR. I've worked in, companies where you get an email from HR every week about whatever the new thing is. You have, group meetings with HR to talk about sexual harassment and things like that. And we may get an email about that, or you have to do an online module as part of our residency training, but we don't have that same prevalence of HR. And then the other thing, going back to your point, I really liked about the medical students is the risk reward is really skewed towards risk, because as a medical student, if you get blacklisted, which I don't think is actually probably that common, but even if you did and you don't get the residency that you want, like that affects the rest of your life. That's it, right? Whereas if you're just getting a job, you don't get the job you want, maybe you can get another job or something like that. But that residency slot, especially if it's a competitive dermatology or something like that, and you don't get it, that's it, right? So are you willing to take that risk? Right. If it's quote unquote not that bad, right? Then you might say, okay, you know what? I'm just going to leave that alone because I don't want to take any risks, because I worked this hard to get where I am and nothing's going to stop me now. Right. So I think that also goes into it. Dr. Umesh, I can see you got something to say.
Yes. So actually, just in line with that, the other aspect that they talk about, burnout and lack of time. Those are two principles that I found very interesting. So going back to this idea of burnout, if you are exhausted and if you are not able to derive enjoyment from what you're doing, they're saying that obviously would have a direct impact in how you behave at work and how you treat the people around you. Simple example, unfortunately, I think I have been a victim to this, where if you are stressed out, if you are tired and you have a ton going on, say L&D triage, you have 10 people checking in, you are running around, and all of a sudden you have a med student who asks, can I present a patient to you? I have found myself time and again being maybe snappier than I would have ever normally been had this been a calmer day, or I had gotten maybe 2 extra hours of sleep. And the fact that I used to pride myself on, being able to check that and make sure I separated my anxiety or whatever was going on from how I behaved. But I myself have fallen prey to that. And so that is one tiny example. But if you were to extrapolate that and look at how you felt about your whole career and your job, I can absolutely see that impacting how you treat people. And hence you may be behaving in a way that you would have never normally behaved.
I think there are two things there. One is definitely when we're sleep deprived. And residency in a lot of surgical fields, especially, but OBGYN, we do a lot of calls. We're up all night. Like our inhibitions may be weakened by that. And so sometimes you do act in a way that you wouldn't, quote unquote, normally act. But I also think that that's a crutch as well. Well, they didn't mean that. They didn't mean it that way. They're not really like that. They're nice. They're just tired and stressed. Right. Yeah. And I feel like we use that as a crutch as well. So, although I agree with you, I like to turn for a second now into what are the consequences of all these activities, this sexism, especially when it's pervasive, is it feeds back into our issues with women in leadership. If you are not being promoted, or if you speak out about sexism and therefore you're not promoted, so you have retaliation, or just that general sense of not being appreciated, of being degraded, I think that's a vicious cycle that leads back to burnout, right? So you have burnout that causes problem, and then it all leads back to burnout again. And people may end up leaving their jobs, their institutions, because of this, especially in places where it's very prevalent. And then for anybody, that's going to not derail your career, but it's going to put a hiccup in your career, because it does take a number of years at one place to build up your CV, to build up your leadership roles, and then maybe you can move to the next institution and move up in the leadership. But if you cut that in half, well, now you're kind of starting over at a new place, right? Or you get labeled as a person who has a problem staying in a job, right? Yeah. And I think, so all that stuff leads back into this overall problem. What really struck me, I don't think any of that is, I don't think anyone's going to be blown away by what was in this paper describing that, but this whole system here And I don't know, I guess I never thought about it in the way that they describe it here, about how interconnected all of these pieces are between the lack of female leadership that we've talked about, the hierarchical nature of medicine, male-dominated field, the burnout, the lack of... It all comes back together. And not to say that sexism or the poor ambient environment of the workplace is responsible for all of that, but it certainly made me think about this as more of a prevalent issue than maybe I did before. Did it change your mind at all about this? Did you see it differently, or were you like, you read this and you were like, yeah, of course? What did you think, Dr. Umesh?
I think the conclusions I'm not surprised by, as you said. I mean, I think this is something that we've addressed, saying that it exists, but I think the underlying issues they're pointing to were definitely something I hadn't considered. The fact that, as you just mentioned, them thinking of this as more of a systemic issue, pointing out the hypocrisy. We as physicians talk about how stress can lead to, increased rates of depression, as the article points out, and women being unhappy, which can lead to psychosomatic events, but yet we're the physicians who are maybe even diagnosing these things, but also propelling these things. And so the fact that they pointed to that hypocrisy, even as obvious as the conclusion is insight that I personally didn't have. And so, yeah, so in short, it seems obvious, but when you really think about it, I think there's definitely more there than we've ever sat down to think about, at least me personally.
Dr. Kim, what do you think?
Yeah, no, I definitely agree that I knew these things existed, but I guess I didn't know how much of a vicious cycle it is, how one feeds into another. I think it's making a huge statement to say like, oh, the sexual harassment is the root of all the way that structure of medicine is. But reading this article, I see how it's a big component of that in the sense that because that there's sexual harassment, it makes a lot of females from the get-go, from the medical student education, when they're in medical school, feel that their self-worth is less than maybe males, and that they can't actually perform as well as males, that at the end of the day that they're viewed as less than males, and that perpetuates itself, so that at the end of the day when they actually become residents and are joining academic institution, they're not going to be going for those leadership positions because they're going to think, well, I'm not going to get it anyway because I'm less than males. I'm in a place where all leadership is already males as it is, so why should I even go for this position? I'm unhappy with my job. I might even leave this place, but I don't want to say anything because, like you said, you need references. If you say anything, there's nobody who's going to speak on your behalf, causing trouble in an institution. So it's a little disheartening to see like, oh yeah, I see that one is feeding into another and there's a cycle, and like, how do you break this cycle? And I know the article mentions, how like the culture change has to begin with leadership, but in my mind, I don't know how to picture that. Because right now, leadership is predominantly dominated by males. And I'm not saying males are the only, people who are guilty of sexual harassment. Right. Yeah. But they kind of set up, but they kind of set up this culture already, and they're the leaders of this culture. And so how do you ask those leaders to break this culture that they've set up and that they are kind of the foundation of? So it's, for me, that was the one point that like I love the article overall, but I was like, how do you break this cycle? And they said the leadership is someone who has to change the culture, and I find that kind of difficult to see how that would unfold.
It's almost disheartening, right? And I mean, and just to add to that, I mean, another idea is that maybe the issue really isn't to target this big lofty goal, but to look at more tangible solutions. So the article pointed out that, for example, some people didn't even have the physical time to file a complaint. If you're, getting through the day, you're exhausted. So are you really now going to file a report, then follow up with HR? And follow through with some of the issues that you've noticed. So say time is an issue. Perhaps one of the solutions could be as simple as creating a dedicated time or a space where these issues have to be talked about. So almost like mandated time that is built into a schedule that maybe removes that barrier to what some people may have as to talking about this. I'm obviously oversimplifying here, but the idea is if we can maybe isolate smaller things and build that into the system, then it takes away from this big mountain that we have to scale to get the larger scale changes everyone's talking about.
Well, I think what you're talking about there is what they say at the end is it's a systematic issue, and it needs to be dealt in a systematic way. And I don't mean, I mean that, maybe I mean systems, not necessarily systematic, but in a systems way, right? Medicine has, over the last 100 years, gone from being individual medicine to more and more systems-based, right? Where we have hospitals and healthcare networks, and you don't work in isolation anymore. In fact, you probably work with 3 or 4 other doctors at any given time. But we haven't switched our thinking for what a doctor is from that individual to that team. Whereas in a lot of corporate structures, I think that, having worked in some, it is a team mostly, right? It's a different kind of, for most fields anyway, it's a different kind of bedrock that you're starting on. And I think your point is well made, that the system has to be altered in ways to make it easier to report. And then, but also at the same time, how do you protect against retaliation and all that stuff? We don't have to invent this, by the way. It's already been done in a lot of the other, corporate structures in this world. So it's not new to medicine. It's just a matter of putting that together with our individualism. Now, the last thing I'll say about this, I suppose, is I think that to ask medical students to be the forefront of this it's a big ask. It's not going to happen.
Right.
I think where you start first is you start with the attendings in the hospital, right? Who are going to say to their co-attendings that that's inappropriate, right? What I just saw you do, that was not kosher. Like, you can't do that, or you made me feel uncomfortable. Right? Whatever it may be. It's really hard. And then if that starts happening and that works, because it's very hard for another attending to retaliate against me. It's not impossible, but it's harder. And then the residents may feel more comfortable doing that. And if the residents feel more comfortable doing that, well, then the medical students might feel more comfortable doing that. But you're not going to get there starting from the bottom to the top.
No.
Because we're hierarchical. It's just
right.
not going to happen.
Right.
So we have to change that. And the last thing I'll say is, I think that, I just said the last thing, but it'll be the second last thing, I promise, is that where you were talking about leadership, we are on the cusp of a sea change in leadership. I feel it in my bones that in the next 10 to 20 years, this field is going to go from male-dominated leadership to female-dominated leadership. And it's just a matter of numbers. There just aren't that many males left in OBGYN.
Right.
It's a lot of women. So just by sheer numbers, it's going to flip on us. In the meantime, though, before we get there, it's up to the males in leadership, it's up to me to also be leaders and say to my colleagues, if I see it, no, that's not appropriate. Like, you cannot do that. And, we take it very seriously at Stony Brook. Like, if you get counseled, and you get counseled again, and if you have to get counseled a third time, you're probably not going to work here anymore, right? And the dean at Stony Brook, I mean, this is, if there are reports in there and you don't do anything about it, the chair will be fired.
Oh, wow.
Like, they'll be gone.
Oh.
Because it can't be accepted, especially it's a state institution.
Right.
They're very heavily policed. If you have allegations against somebody and it is not addressed, gone. Now, unfortunately, that really only takes care of the big stuff.
Right.
The sexual coercion, right, and the unwanted sexual attention. That ambient, gender-based harassment is much harder beast to get a hold of. So, I do have one more thing, and I meant to say it from the beginning, Vi, and that is about zero tolerance. Right? If we're going to fix this, there almost has to be zero tolerance, because we are so much on one side of this that, yes, we have to overcorrect. It's going to take a while to pull us back to the middle, right? And yes, I don't want a witch hunt. No, I don't want every male to be fired from OBGYN for joking with their colleague. But at the same time, if we tolerate even a little bit, like, we're never going to make any progress back to where we should be. So I really feel that we need to overreact a little bit to get where we want to be. I just talked for a while, so I don't know. Dr. Kim, what do you think about everything I just said?
Yeah, no, I think, especially the last point, I was going to say that I think zero tolerance is extreme. But if there are actually nothing that comes out of reporting, and you report, and nothing happens, then no one's ever going to report, and nothing's going to happen. And people then lose faith in the system, then lose faith in the leadership. And I think that's going to breed other problems. So if you're going to make this an agenda, we're going to address this, and we're going to make sure this is our priority, to make sure that, that sexual harassment, if it happens, there'll definitely be repercussions from that. We need to see it carried out, or else people will be like, well, they'll probably let this one slide by like the last one, or like they'll let me off like lightly, just like the other person, because who's to say that, if that person did it, why can't I do it? So unless you have like a really strict policy in place, I think I agree. I don't want someone, like every single person, even the slightest remark, now they're fired. That's, it is a little extreme, but I think it's necessary in some regard for people for a complete culture change of how we think and how we approach and our medical students, our own colleagues, and just of the workplace in general.
Yeah, absolutely. I think defining a scale is essentially what zero tolerance would allow us to do. Right now, that gray area is very confusing, and although the nuances are important, unfortunately, as you mentioned, Dr. Chappelle, it ends up in us just continuing to overlook all these little nuances and no change is ever made. So perhaps zero tolerance needs to be important because it makes it easier for people to know what is appropriate and what is not. And it also, I think, will make people a little bit more hypervigilant in their own actions, in maybe thinking once before saying something, or being more even self-scrutiny, I think would be very important in helping to alleviate a lot of the behavior that can become problematic. And the second point I wanted to make is, I think it is absolutely important. Hopefully what the zero tolerance would create is, as we've talked about, a revamp in culture. And the reason I think that's important is we've now defined, say, male leadership as being one of the issues. But say all the men in leadership eventually go out of leadership. If you've grown up in a culture where some type of behavior is acceptable, I don't have full faith that that behavior won't get propagated if you remove, say, one problem. I think the culture is the problem that needs to be fixed. Simple example, as residents, we've noticed now when I look at some of the interns, say a simple thing like postpartum rounding, we've talked about, maybe we'll get a nurse to help us on the weekends. My first instinct was, well, I did it without a nurse, so why can't they do it? I don't even see why everyone's complaining. But then immediately I remembered when I was an intern, people said that, and that was hard for me to swallow. So how quickly I changed my perspective was a little frightening to me, to be honest. So if somebody like me with only a year and a half into this program is so malleable in terms of my thoughts, what is to say I won't be like this if I've grown up in a culture that propagated this?
Don't be worried, Vi. You're just human. Right? We all have a tendency to say, I think I am a good doctor attending fourth year, third year, second year, and therefore the process I went through must be why I am good. Mm-hmm. Right? Yeah. And that is why people still spank their children and do other things, right? Because that's how they're raised, and they turned out okay. Mm-hmm. Now, of course, they have no objective measurement whether they think they turned out okay. They just think they did, but that's a different story. But we say that all the time, and I always fight against that myself, is to say, I believe that this thing that you guys do is good, right? This part of training. And I have to say, okay, why do I feel that's good? What objective is that addressing? And is it really good? Or do I just feel that it's good because I went through it? Mm-hmm. And that's been hard for me to do over the years too. You guys know I like to tell stories about when I was a resident, right? But a lot of that actually is just to remind people that it wasn't always the way it is today. Because I think I would say residents have at max a 3-year memory, because the longest resident is there for like 3 years of training, and then they're in the fourth year and they're gone. So the residency only has like 3 to 4 years of memory. So if it happened 5 years ago, to the residents, it never happened. Right? So it's important to know that things change, and in the course of 3 or 4 years they can. I don't know where I was going then anymore. But anyway, you're human. I think that was what I was trying to say. But we do have to fight against that. And I think that you're right. That was what I was going to say. I think you're right, Vi, that just changing from male to female is not going to itself change the problem. It may decrease some of the sexism in general, but there are other kinds of mistreatment, and we're not probably going to get through that today because we've already gone on for a while. But there's also, just being mean to the medical students. There's ignoring them. There's treating them as if they're useless or they're dumb. And we see that all the time, and you don't have to be male or female to do that to somebody else.
Exactly. Yeah.
And so there's a different component of it that is outside of sexism, although they probably have similar roots. So I guess, is there any way we can incentivize this? Can we make it better? I don't know. I think we've already said yes, but it's going to take a long time and a lot of work. I don't know if you either of you have anything else more concrete to add than that, unfortunately.
Say just incentivizing. I mean, it can be as simple as maybe physicians who get better ratings from their colleagues get better bonuses. I mean, it can. I mean, we talk about that with patient outcomes.
We're laughing, but that's
more.
not crazy.
No.
Patient outcomes is how we get compensated. So maybe, I mean, it would be a sad state that, that's what it really has to come down to affect change. But I mean, I'm sure there's going to be incentives in some sort of degree like that would perhaps help. But
I mean, the sociologists will tell us that humans are pretty predictable animals. And if you pull the right levers, then we'll do things, right? So money is usually a pretty good lever for a lot of people. So that is not a silly suggestion.
Yeah.
So I want to come back around to something that Dr. Kim talked about at the beginning, was the other kind of sexual harassment or not sexism, not harassment, but sexism that is mentioned in this article, and that is between patients and their doctors. And that is probably a lot harder for us to tackle because the patients don't work for us, and we have no levers on them. So I want to finish up and say, what do either of you think? Is there anything we can do about that, or do you think that's something that will just change as the overall society changes towards less sexism? I don't know. What do you think, Dr. Kim?
Yeah, I mean, definitely that's an issue that's difficult to fix because I can't force a patient to be like, okay, I want you to take this education class about, tolerance and how you have to, raising cultural awareness about, I guess, the dynamics at workplace, etc. But I think a lot of that could just be the patient's own perception of how the structure of medicine is, because they do see kind of on the surface, the leaders are males, so they're going to feel that the males are the more competent, the more, who dominate the field. So if they say, oh, yeah, all the chairs, all the, division directors are all males, they're going to assume, oh, yeah, males are the ones who are better, which is why they have these leadership roles. So I personally think that as that society changes and that's the medicine leadership kind of model changes, and like I say, especially in OBGYN, as more and more females will probably take leadership roles just because of the makeup of our profession right now. I think patients may kind of let go of that over time of, oh yeah, males are the ones who are definitely more qualified, which is why they're being leaders in this profession.
Yeah. I was going to say, just in line with that, some element of normalizing it. So yes, we could, I think, in all actuality, I think as society changes, that is going to be sort of the biggest impact that we hopefully will see in patients' perceptions of their providers. But another idea is helping to normalize it. So oftentimes medical students do not get to participate in care because patients only want to be seen by a doctor or only want female students and things like that. So one I guess, intervention or so to speak, or change in action that I've tried to do, which has helped, is normalize it and say, oh, this member is a part of the team. So everyone gets seen by them, then they tell me and I tell the attending. And that is just the standard of care. So I think by doing that, perhaps it helps set the tone too, to say this isn't weird. I'm not a scapegoat. I'm not a guinea pig who's getting tested on by all these people. And maybe more actions to that extent. I mean, a lot of people now, when they come into Stony Brook, say, I know it's a teaching hospital. They usually preface them saying, I don't want to see you, by saying, I know it's a teaching hospital. But so the fact that they even acknowledge that, I think, is a step in the right direction. But I think maybe more to sort of level the playing field could be helpful.
Well, that goes back to what you were talking about earlier with the team, as opposed to individual. So you are really making a team out of your medical student, your resident, your attending, and saying we are all parts of this that work together to make sure that you, the patient, get good care. Right? And each of us is essential for that. Right? And I think we're right. I think if you describe it that way, most patients will be okay. And again, that goes back to our other ways of mistreating medical students. One of the big ones on that list was being ignored.
Mm-hmm.
Right. And it has many reasons. A lot of it is you being busy, not wanting to not wanting to take the extra time with them because you have other work to do. And that's a whole other discussion we can have about how we arrange healthcare in this country and how we pay for it. But I think we're going to avoid that for right now because we'd already been going on for a while. So anyway, this is obviously not going to be the last time we talk about this topic, either as a society or on this podcast. I know that I personally am passionate about it, and I know that all of my panelists, even the ones who couldn't be on tonight, are passionate about this because I saw their emails.
Yeah.
So we will come back to this. But I think this paper, and I hope our conversation, was a good start at really saying there is this pervasive issue in medicine that in order to do something about, we first have to recognize. So let's recognize it, know it's an issue, and even if we don't solve it overnight, we can start doing those little micro things day to day that make it a little better. So I want to say thank you to Dr. Kim for joining us again and for this difficult conversation.
It was a pleasure to be here.
And Dr. Umesh, thank you for coming and being part of this. I look forward to having you back on again soon.
Absolutely. Thank you for having me.